talking about TBI, traumatic brain injuries, in the Glasgow Coma scale in the motor section. The interesting part that we're talking about is the decerebration versus the decortication. And basically, by definition, both decerebration and decortication posturings are both pathological posturing response to whatever noxious stimuli, whether it's an internal or external stimuli. But here, for example, we're talking about TBI, which we're concerning about external traumatic brain injury. And basically, the cortication or decerebration, you'll see at times they say, oh, this is the flexure posturing or the extensor posturing, and we'll talk about that more in details. I want to explain to you that whatever differentiate, so here's your brain. And I like to think of it in a way, okay, this is to simplify things, okay? So this is your brain cortex, and this is on top cortex, on top cerebrum, and your cerebrum, cortex and cerebrum. And to differentiate between things, you know that the lesions above the red nucleus and below the red nucleus, these are the lesions that will determine whether the patient is decerebrated or decorticated. And so that we know, decerebrated is worse on the Glasgow Coma scale from decorticated. Okay. So, and usually when they talk about etiologies, they will tell you, okay, so is this a supratentorial etiology, or is it an infratentorial lesion, or this is just a diffuse or a metabolic etiology? That being said, basically these two are kind of the same. So we're talking about abscesses, we're talking about trauma like in the TBI, we're talking about hemorrhages, we're talking about tumors, and then we're talking about diffuse or metabolic. We're talking about whatever electrolytes imbalance, whether it's hyponatremia, hypernatremia, encephalitis, patients with hypoglycemia, diffuse axonal injury, patients with meningitis, hypoglycemia can cause it. That being said, when we're looking for the lesions of decorticated versus decerebrated, we need to understand the difference. So decorticated is when you see a patient, the patient will be flexing his upper extremities. He's going to be extending his lower extremities. And basically thinking of it this way, when a patient is having decorticated, they will go to their primitive reflex, because the cortex is one of the things that differentiate us from other mammals. So they will go back to their primitive reflex. So they will go back to the primary muscle groups that are in charge of motion. What do we use for lower limbs? What are the stronger muscle groups? Are the extensors, because these are the anti-gravity muscles. And the upper extremities are the flexors, because these are the muscles that we use more to lift things. So these are the primary muscle groups. So once you're decorticated, you go back to your primitive reflexes, your primitive tracts, and you'll find that these are the stronger ones. So when you're having these lesions, you will see that the decorticated posturing is basically, you see that the patient has abnormal flexion of his arms, and you'll see them having extension of their legs. Usually it involves elbows, wrists, and fingers. At times they will see adduction and internal rotations of the shoulders while that is happening. I'll see extensions of the hips, and there's internal rotations of the hips as well. And all of that is based on the primary controlling muscles. When we talk worse, and the reason why it's decorticated, think of the blood supply going this way. Again, this is not anatomically correct drawing. This is just to explain it in a simple form. What area gets ischemia first is the cortex, and then the cerebrum, right? And think of any lesions above the red nucleus. That being said, if we're talking about decerebration, these patients will kind of have the opposite, right? So you'll see that these patients are starting to have, yes, also adduction and internal rotations of their shoulders, but we'll see they're extending their upper extremities more than anything else. And when it comes to the lower extremities, when it's extensive, you will see that they are having still extension of their knees and plantar flexion, but they will start having plantar flexion of their feet. So they will be extending all over in a way. So the main one that you'll differentiate between them, and that you'll mostly see on someone doing noxious stimuli in the Glasgow Coma scale assessment to measure the motor reflexes, and you'll see that they're having either flexion of the upper extremities or extensions of the upper extremities. It's based on their decortication or decerebration. It's a simple matter of fact that needs some understanding to be. You don't have to memorize it, you just have to understand the different stages of brain injury and where it's going. And also, I will attach an article down here. I think it talks about it in a simplified way and only talks about that part in the Glasgow Coma scale. So you don't have to memorize more, you just see the severity based on it, you know where the lesion is, you know why the body is presenting this way. That being said, moving forward with the rest of the Glasgow Coma scale,